Hello everyone, I'm Jon Salmanton-García from the University Hospital of Cologne, and today I will speak to you about the epidemiology of SARS-CoV-2 infection in hematology patients. These are my disclosures and also the disclosures of Epidemiology, as all the results I will be presenting today are coming from different Epidemiology publications. And just as a bit of background, as we all may know, hematological patients are at a high risk for underlying infections due to immune deficiency and antineoplastic treatment. These infections can be caused by different pathogens, and between others, we have bacteria, fungi, or viruses. And precisely on viruses, I will focus today, more exactly on SARS-CoV-2. One relevant date for SARS-CoV-2 is March 2020. In this moment is when COVID-19 pandemic was declared by the WHO, and we all started focusing and looking for this type of patients. From the overall number of COVID-19 patients with hematological malignancies are around 2 to 3%. And this has been stable during the whole pandemic. Another relevant date is December 2020, and this is because the first anti-SARS-CoV-2 vaccines were made available. However, in patients with hematological malignancies, they may have limited efficacy in some of them due to precisely the immune deficiency and the potential antineoplastic treatment administered in these patients. The presentation will look as this, with this color coding. From now onwards, we will have data from before the vaccination area in green, from vaccination area in blue, and specific data from the fourth dose or from patients with a fourth vaccine dose in yellow. If we look for the data regarding sex, we won't really find any big difference depending on the evolution of the pandemic. It's been always more or less stable, 40% female, 60% male. But if we look for the age, for example, we can see how, according to the evolution of the pandemic, the population in hematological patients has, or the age in this population has increased. And that way we can see how in between the patients with 4 vaccine doses, there is no one below 25 or younger than 25 years old, and actually those between 26 to 50 years old are located in the upper limit of the range. For comorbidities, the main comorbidity beyond, of course, the hematological malignancy, it's been cardiopathies. Afterwards, diabetes mellitus, lung disease, or smoking history. And we can see how, according to the evolution of the pandemic, the level of patients with cardiopathies has increased. At the same time, patients with more than one comorbidity have decreased, and now we have mainly patients with only one comorbidity, of course, again, beyond hematological malignancies, or patients with no comorbidities. Regarding the baseline malignancy, most of the patients, and this has remained stable, are patients with non-Hodgkin lymphoma, afterwards multiple myeloma, acute myeloid leukemia, and chronic lymphoid leukemia. Patients with other malignancies were more present or were more prevalent actually at the beginning of the pandemic as compared to the current data, as now the main malignancies or the malignancies have been focused on the 4 types I just mentioned. Regarding the state of the malignancy at the COVID-19 diagnosis, we can observe how the number of patients with an active malignancy have decreased, and we only have now 10% of patients with active malignancy at the beginning of COVID-19, and this is a relevant factor, as we will see in the following slides. Regarding the white blood cell counts, we can see how it's not really frequent, either neutropenia or lymphopenia, in both cases between 5 to 10%. And regarding the severity and the treatment of COVID-19 episode, we have seen how the severity of the patients has decreased. depending or actually with the progression of the COVID-19 pandemic. And this is related to the admission to hospital. We were at the beginning with a 70% of hospital admission rate, and now we are around 40. And regarding ICU admission, we have moved from 20% to now only 5% of patients admitted to the ICU. If we focus now on the right section of the slide, we will see the treatment for COVID-19. In this case, there is no data from before the vaccination area, as at that time, the protocols might be pretty different depending on the institutions. With the current data, we can see how more than 40%, 45% of the patients don't receive any treatment. And between those that receive a treatment, basically it's antivirals, monoclonal antibodies, or a combination of both. And plasma, for example, alone or combined with corticosteroids is no longer administered. Mortality rate, quite a good variable to measure the outcome in the patients. 30% at the beginning of the pandemic, and now we are around only 5%. And if we focus on the reason for the mortality, we can observe how every time or all the times it's been mainly related to COVID-19 infection. Regarding to the mortality per the different malignancies, we can see how, of course, the highest mortality rates are focused in the 4 main types of cancer, but we can see a huge decrease in non-Hodgkin lymphoma and also in multiple myeloma, a complete disappearance in lymphoid leukemia, which is a cancer mainly appearing in elderly people, has remained stable. At the same time, in myelofibrosis or in hairy cell leukemia, we can see how it has increased from pre-vaccine to post-vaccine areas. But we must say that here we have a very low sample, and a single patient can change a lot the results. And which are the factors associated to mortality? Well, regardless of the vaccination, we have increased age, active malignancy at the beginning of COVID-19, also COVID-19 progression, and especially admission in the ICU unit, and the presence of 2 or more comorbidities. Now in Omicron, for example, we can evaluate the role of the vaccination, and we can see how no previous vaccination is associated with an increased mortality, and also it's associated with an increased mortality, the treatment only with corticosteroids, or the treatment, in this case for Omicron, without monoclonal antibodies. If we want to see whether the differences in the mortality are statistically significant between the different main or the 4 types of malignancies, here we have a survival probability analysis, and we see that it's similar. There is no statistically significant difference. If we focus on the treatment, we will see all the time that patients receiving monoclonal antibodies have a higher survival probability as compared mainly to those receiving plasma. And if we focus also on treatment but stratifying by the severity of COVID-19 infection, we can see how this happens in asymptomatic patients, in patients with mild infection, in patients with severe infection, and also in patients with critical infection. And in this case, we can see how the best options, or the options with a higher survival probability, are the reception of monoclonal antibodies with or without antivirals, and it presents a higher survival probability 30 days after COVID-19 diagnosis compared to any other treatment option. And last but not least, simultaneous diagnosis of malignancy and COVID-19, pretty interesting. We did an analysis, there was already a specific video published, and we can see how most of the patients are male in a similar proportion to the general hematological malignancy patients, 65 years old. They have 2 or more comorbidities, normally heart disease or diabetes mellitus. The malignancies are 1/3 acute leukemia, 1/3 non-Hodgkin lymphoma, and the remaining third all the others. And the time from the malignancy diagnosis to COVID-19, normally it's around 11 days, occurring first the malignancy diagnosis and then the COVID-19 diagnosis. Most of the patients, 85%, are admitted in the hospital for around 15 days, and in the ICU, 1/4 of the total patients for around 8 days. COVID-19 treatment is, or actually there is no COVID-19 treatment for 2/3 of the patients, corticosteroids in almost 20%, and antivirals in 1 in 10 patients. And mortality is associated with age, ICU admission, 2 or more comorbidities, and the lack of malignancy treatment. And focusing precisely on this, we can observe how the mortality in patients with no treatment for malignancy is 42%, whereas the mortality for patients with treatment for malignancy is 27%. In this graphic, we can observe it more clearly, and we can see how there are statistically significant differences. And now the very last slide. In case you would like to participate in the EpiCOVID registry, you are still on time. You just need to document patients with a SARS-CoV-2 positive test and with an active malignancy during or within the 5 years prior to COVID-19 infection. The benefits are access to a large sample with more than 8,000 patients with hematological malignancies all around the world, authorship or collaborationship in case your patients are included in 2 analyses, and you can lead your own research with access to the whole sample. So far, we have more than 160 partners in more than 40 countries in all the continents in the world, and you can see in the right lower corner which are the upcoming publications. In these slides, we can see which are the publications that have been already released, and remember, in case you want to participate, please feel free to contact us either via email or via Twitter. Thank you very much, and see you next time.